Hello, I'm Dr. Joe Gerstein, one of the founding members of Smart Recovery, and I'm here to tell you a little bit about Professor Richard Saitz, a great friend of Smart Recovery. He was a professor of medicine and community medicine at Boston University Medical School, and he was the editor of a number of journals, the chief editor of the Journal of Addiction Medicine, and an associate editor of the Journal of the American Medical Association. A few years ago, he was the keynote speaker in Chicago at our 25th anniversary conference, talking about his other favorite subject, stigmatization. We have, fortunately, a memorial series of lectures to memorialize his devotion to smart recovery. Rich Saitz was born and brought up in the same section of Boston that I was, and we reminisced many times about our experiences. He was a great friend of Smart Recovery. He was a wonderful physician and researcher, and especially editor, and we will miss him dearly.
Good evening, everyone, and welcome to the Richard Saitz Memorial Lecture featuring Dr. William Miller. I am Pete Rubinis, the Executive Director of Smart Recovery. Before we begin, I just have a few housekeeping items to run through. This is a lecture, so chat is disabled for this particular Zoom meeting. You may enter questions in the Q&A box, and I will moderate asking Dr. Miller some questions if time allows at the end of his remarks. The lecture will be recorded and posted to the Smart Recovery website sometime tomorrow. Now to introduce Dr. Miller, I'd like to introduce one of our co-founders, Dr. Joe Gerstein. Joe, please take it from here.
Hello all, and welcome to the second Rich Saitz Memorial Lecture. I have a very easy job tonight of introducing someone who needs no introduction. I'm sure everybody who is tuned into this is familiar with Dr. Miller and his great activities and originality of his work. We did publicize a brief summary of his accomplishments. He, of course, was one of the originators of motivational interviewing in the 80s and spent the next 40 years spreading it throughout the world. Not only spreading it in terms of geography, but in cross cultures and across special interest areas of science. Many medical schools now teach it as part of their curriculum. And certainly it infuses every element of the Smart Recovery program, whether the standard Smart Recovery addiction program, its family and friends program, or its correctional versions, which are also spread around the world. And so ordinarily, I would be inviting Dr. Miller to the podium, but in this era, we invite people to the microphone and the camera. Welcome, Dr. Miller.
Thanks very much. There we go. Well, I'm really pleased to do this for Smart Recovery and to memorialize Rich Saitz, who was also a valued member of the Motivational Interviewing Network of Trainers for some years. I titled my talk "Going Upstream" because that's sort of what I've been trying to do all through my career, and it was an interest of his as well. And I'll give you just a little bit of history about that. It started for me when I learned about alcoholism. When I interned at the VA in Milwaukee, and I visited the alcoholism unit, Robert Hall, who was the director of the program, said, "What do you know about alcoholism?" I said, "Well, nothing really." said, well, what did you learn in your graduate courses? And I said, I don't remember it ever coming up. He said, well, this is something you better learn about because it's probably the second most common diagnosis you'll see through your lifetime. And he got me interested in the field, which became a career-long focus of mine. What I saw there on the inpatient unit was pretty severe, long-term devastation of alcohol dependence. And I decided I might rather go upstream a bit and try to find people sooner. You may be familiar with this diagram, that there are a whole lot more people who are at risk than actually have a diagnosable alcohol use disorder. And we used to differentiate dependence from other alcohol use disorders. We no longer do. So now it's all one continuum of severity. But rather than trying to just focus on people most severely impaired, I was interested in trying to get to those who were at risk. One thing I did was to develop a program to help people learn to control their drinking, which in the 1970s was not exactly popular. The common belief was either you're alcoholic and you're unable to control your drinking, or you're not alcoholic and you have no need to control your drinking. And of course, both of those things turn out not to be true, but at the time that was the belief of the time. That book is still in print, astonishingly, so it's had a pretty good life. We did 10 years of research before I finally decided that was as much as I could do research-wise with this method that just didn't seem to be timely in the 70s and 80s. We got an average reduction in drinking by about 50%, medically significant reduction in drinking. Discovered that a self-help book version was just as effective on average as working with a counselor using the same method. Showed that it's better than putting people on a waiting list. And we did 2 to 10 year follow-ups, and the reductions in drinking maintained very well over a long period of time. And so did alcohol-related problems. So this, as an intervention, was quite successful, actually. It just wasn't timely at that point. We also found that people who were higher in alcohol dependence were less successful at moderation, and were actually more likely to quit drinking in the long run. In fact, in our 10 years of research, more people wound up quitting than actually maintaining stable moderation over time. And among the more dependent people, they told us one of two things. I thought they might try moderation, fail, and thereby conclude they needed to quit. Instead, what happened was they tried moderation, didn't like it, and decided to quit. And they would say, this is an awful lot of work. I feel like I'm on a tightrope. I could fall off anytime. And what's the point in drinking so little? And so consequently, the moderation program actually wound up helping people decide to abstain, not because they failed, but because they realized that moderate drinking was not what they wanted to do. NIAAA now recommends screening, as you probably know, for alcohol use in primary care, and recommends reducing your drinking into a medically low risk or abstinence level. In fact, the percentage of Americans who are abstainers has been going up, and it's 71% of adults now are either non-drinkers, they don't drink alcohol at all, or they only drink occasionally, less than 1 drink a week. And I think many people are not aware of that, particularly drinkers are not aware of it. And it's pretty clear that even low amounts of drinking do have associated risks attached to them. These are just some bars of non-drinkers in blue. These are people who don't drink at all. And then the kind of rust colored is occasional drinkers, less than a drink a week. The green bar is 1 to 7 drinks a week, and the purple bar, more prevalent in males, is 8 or more drinks a week. But in all of those sectors, the abstainers and occasional drinkers outnumber the rest. Even among the men, they represent a majority of American adults. What about alcohol use disorders? They're an awful lot like chronic illnesses. They're highly prevalent around the world. They're definitely directly related to behavior and lifestyle, as well as some genetic factors that increase risk. For example, a high tolerance for alcohol puts you at greater risk of developing problems with alcohol. Usually these things develop gradually over time. They don't just have a sudden onset, although it can happen, but more like hypertension and asthma and so on. They kind of gradually emerge over the years. They occur all along a continuum of severity, and that's the way the DSM is written now. So just like diabetes and hypertension, they go all the way from mild cases to severe cases. There are effective treatments, but not a cure necessarily, that are available. They're much easier to treat earlier if you catch them earlier. They have a high mortality if they're not controlled. And they're not usually resolved in one single episode of treatment. That's certainly true of diabetes and hypertension and heart disease and all kinds of other chronic illnesses. And recurrence is normal, as it is with chronic illnesses. People often are coming back into primary care for additional assistance, for adjustments in the treatment and so forth. And we take that for granted with chronic illnesses, but not with substance use disorders. What's different about the way we treat substance use disorder? Well, they are, as Rich knew, highly stigmatized. We use language that's shameful. With people with drug addiction, we talk about them as clean or dirty. Abuse is a term that we've now abandoned, but it was around for a long time. As if you're being abusive of a drug. Terms addict and alcoholic are attached to an individual rather than to a disorder. The concept of relapsed is problematic in my view. It's not one that we talk about much with chronic illnesses, but it certainly is with substance use disorders. And even denial that there's something wrong with the person, that they're not recognizing that this is a problem. And typically addiction treatment centers, the places that specialize in treating substance use disorders, are geographically separated and even isolated from healthcare. We have at the University of New Mexico hospitals an alcohol, substance use, and addiction program. This is where the university hospitals are in the University of New Mexico, kind of right in the center of Albuquerque. But here's where the addiction treatment program is, in a warehouse district out by the airport, away from the hospitals. And why was that? Well, we don't want those people around the hospital. Well, guess what? They're already there being treated for all kinds of things. But still, we tend to separate and isolate and stigmatize these conditions. We tend to treat substance use disorders like they're an acute illness. You get treated and then you should be over it. We don't do that with diabetes. We don't do that with heart disease, but we have these 21-day, 28-day treatment programs, and then you're supposed to be done with it. They're just episodes of specialist care, but often not much attention given to these disorders in primary care. Now, NIAAA and NIDA are working on reversing that and having this be part of the job of primary care physicians, but still largely not the case. Patients graduate from treatment programs. They're discharged, their case is closed. Well, you don't see that with diabetes, but it's the way we think about addiction treatment. And also, we tend to think there are only two possible outcomes: perfection or disaster. And we calculate success rates in treatment programs for alcohol problems, for example. But when was the last time you heard a success rate for a diabetes treatment? We just don't think that way. What about this? This is from Tom McClellan. This is level of symptoms before treatment on the left, and then during treatment, and then after treatment. Now, in the addiction field, that's thought of as a failure. Nothing, had no benefit. In pharmacotherapy, that's thought of as proof that treatment works. So we have these different standards about what's successful. relapse rates, that was when perfection is the standard, most people don't stick with it. These are survival curves, meaning once you have used, you're gone. You can never get back on the curve again. And it gets down around 20, 30% who are still left after 12 months as not having used, not having drunk, not having smoked, not having taken a dose ever. And we've known that since the 70s. It's been true for a long time. Here are the survival curves in the biggest clinical trial ever done of psychotherapies for alcohol use disorders. And again, you see about 25% or so are still there on the survival curve. 75% fell off of it somewhere along the line and are thought of as failures. But they're not. Here are average outcomes for over 8,000 people who are treated for alcohol use disorders, combined across 7 multi-site trials. What we found was 1-year outcome, which has been very consistent across 40 years of research. You get about a 1% to 2% mortality, which is somewhat higher than general population stats, but not that much. 24% maintained perfect abstinence for 12 months. What about the rest? That would make 75% failures. But among those who did drink, alcohol consumption decreased dramatically, decreased by 87%. And alcohol-related problems the same, dropped down by 60%. If this were any other chronic illness, one quarter of the population, total remission. And for the other 3/4, 89% reduction in the primary symptom, that would be a remarkable success. But in the addiction field, we think of it as terrible outcomes. So what's the standard? In chronic illnesses, we don't tend to compute success rates. It just doesn't quite fit what we know about managing chronic illnesses. We don't treat them like acute illnesses that can be solved in 21 or 28 days. We don't tell patients they've relapsed. If a person with diabetes comes into the emergency room in a hypoglycemic crisis, we don't say you relapsed. It's not done. And recurrence of symptoms is regarded as the norm, not a failure of the program, not a failure of the treatment or the provider or the patient. Rather, it's a need to adjust treatment. A third thing is we really don't require the use of evidence-based treatments. We require people in some states to say they use evidence-based treatments, but it's not audited really. And addiction counselors are among the lowest paid, lowest status, lowest educational requirements for any healthcare providers. We had debates in New Mexico about whether a high school education should be required, and then about whether a college education should be required. That wouldn't be the case in very many healthcare professions. We accepted shameful treatments in the addiction field that really would be regarded as malpractice in treating almost any other health problem. But they were accepted as the norm. For some time, you still find them around. And what about waiting lists? We put people on waiting lists to be treated for substance use disorders. But we know that even brief interventions, and Rich Saitz was very conscious and teaching of this, even brief interventions can have a significant impact. Here's a study in which we randomly assign people to get a brief intervention and some self-help guidelines, or to immediately be seen by a therapist to get a behavior therapy very similar to what's in the written guidelines, or to be put on a waiting list. What we found was the waiting list didn't change at all. The orange line, those being treated by a therapist, nice reduction in drinking. But those given the brief intervention and self-help guidelines, also a nice reduction in drinking that maintains over time. The waiting list doesn't change at all, which is kind of odd in that these people all presented asking for help. They all accepted admission into a clinical trial. They all got a thorough assessment of their alcohol use, and yet no change. until we treated them, and then they got better. And it didn't maintain quite as well, which is something else we found in waiting list controls. I used to think this was an ethical control condition because everybody got the treatment eventually, but I don't think so. I think now putting people on a waiting list is pernicious, as it gives them the wrong message. What we realized back here is that they were doing what we told them to do. They were waiting. They're not doing anything differently. But if you tell people to do something differently, they do. So if you say you're on a waiting list, that's implying to them there's nothing they can do until we give them our expert help. And so they don't try. But if you give people something effective to do instead of waiting, they do it often. And by the time they're off the waiting list, they may not need you anymore. Or at least you'll be working with people who have more severe problems and more in need of direct help. Not true just in substance use disorders. This is a study with people meeting criteria for depression. And we assigned them in a randomized trial to one-to-one therapy or small group therapy or large group therapy, all of which were 8 weeks in length, all of them the same cognitive behavioral content, or to get a self-help book with the same material in it and go home. And we said, we'll see you in 10 weeks and see how you're doing. Or a waiting list control group. And we said, we'll treat you in 8 weeks. What we saw again was the least change in the waiting list group. The large group didn't fare as well as individual and small group, but the other three, individual, small group, and the self-directed treatment group, all reduced their depression symptoms down below the cut point for depression. Tom Bean and I and Scott Tonigan wrote an early article back in the 90s, trying to figure out what is it that seems to be characteristic of effective brief interventions for alcohol use disorders. And we came up with this acronym of frames that you may have run across. These things were often common when a brief intervention worked. People got feedback about their own status, often test results or something like that. So they're learning something about themselves. Or we measure their drinking amount and just tell them how much they're drinking relative to norms. But they also imply responsibility for behavior change. They also imply that it's up to you to do it. It's not something else that somebody can decide for you. Nonetheless, there is advice to change, and a menu of options are provided. Empathic counseling is the style that's usually there. So when there is some kind of counseling provided, it's done with a listening, compassionate, empathic way of being with the person, and always support self-efficacy. Always encourage hope that it is possible to change this. You can do this. So those were elements of effective brief interventions. Motivational interviewing, we particularly have focused on the concept of ambivalence, which is normal part of human nature. It's really common around health behavior. Here you see a fitness center and people going up the escalator. It's also common in healthcare. Give it to me straight, doc. How long can I ignore your advice? It's in popular music. How can I miss you if you won't go away? Nick McCarthy, or my personal favorite, Billy Ray Cyrus, I'm so miserable without you, it's almost like you're here. It's been around a long time too. Fletcher Henderson in the 30s. My sweet tooth says I want to, but my wisdom tooth says no. So simultaneously, you want and don't want this. With health behavior change, people know they need to do it. Or part of them does at least, and part of them is perfectly comfortable living their lives the way they did before. Both things are true. That gets pathologized in the addiction treatment field, even though it's quite normal. There was even a Roman god with these two faces, one looking forward, one looking back, was the god of change and transitions and doorways. So it's actually very normal to both want and not want something at the same time. Nothing pathological about that. And in fact, if you know the theoretical model of change, it is one of the normal stages of change, which is called the contemplation stage. In pre-contemplation, you're not ambivalent. You see no reason to change at all. But in contemplation, you're thinking about it. You can see some reasons to change. You can see some reason not to. And the decisional balance is kind of going back and forth. That's what contemplation is all about. And in that sense, ambivalence is a step toward change from pre-contemplation that's come before it. So it's a normal part of the process of change. Let's just go in and say these two ladies who don't need banana cream pie, let's just go in and see what happens. We've gotten really interested in human speech about change and have this concept of change talk, which is anything the person says that favors making the change, and sustain talk, which is anything the person says that kind of argues against making the change. And it's almost like there's a committee inside the person where the members are arguing for and against the change. And you can hear it in speech. We came up with these categories of change talk. 4 of them we call preparatory because they're kind of getting ready for change. One of them is desire. I want, I wish, I would like. One of them is ability. I can, I could, I'm able. One of them is reasons. Well, if I did, this good thing would happen. Or if I don't, this bad thing will happen. And need language. I must, I need to, I've got to, I have to, without necessarily giving a reason. So those are things we've found that people say that are starting to talk themselves into change. Mobilizing is getting a little closer. So when you're hearing these things, it's closer to actually happening. Commitment's the strongest of them. I will, I'm going to, I promise you, I swear. So this is ways in which we make contracts and promises and agreements with each other. Almost there, things that we call activation language. I'm willing to, I'll consider it. We wouldn't accept that at the marriage altar. There you want a commitment, but activation language is pretty close. And then taking steps, something else we noticed, people would come back and they had done something to move themselves closer to change. I bought a pair of running shoes so I can exercise. I got rid of all the cigarettes in the house. So it just took a step that, again, that's something that predicts change actually happening. Now, it turns out all kinds of change talk actually favor change happening. You don't have to hear commitment. In fact, it's not even necessarily a good idea to press for or push for commitment. Any of these kinds of change talk, when you hear them, rejoice and be exceeding glad, because it's the person talking themselves in the direction of change. For smoking, desire, I want to quit smoking. Ability, I think I could. Reasons, I've been feeling short of breath lately. Need, I've got to quit. Commitment, I'm going to quit. Activation, I think I'm about ready to quit. Whoop, got quite there. Taking steps, I got rid of all the cigarettes in the house. So they're just examples of these 7 kinds of speech talk, of change talk that you can hear and should notice when you hear it, because those are important things you just heard. They often come intermixed with sustained talk. Desire language about continuing to smoke. I really enjoy smoking. Ability language, I don't think I could quit. Reasons, I have to smoke in order to relax. I have no other way to take the pressure off. Need, I don't think I need to quit. Commitment language, I'm going to keep on smoking. That's commitment. I'm not willing to quit. Activation language. I bought 4 cartons today. That's taking steps to continue smoking. So these things can happen on either side of the equation. And the balance of that equation does tell you how likely it is that change is going to happen. So that decisional balance when you're listening tells you how close you're getting to the person actually doing it. And what's important is you influence that balance. So you don't have to just sit there and wait to hear it. The things that you do and say in sessions make a difference. Here is a clinical trial in which the counselor changed their style every 12 minutes. You can imagine that. So the counselor's sitting here, the client sitting in front of them. There's a signal on the wall behind them that tells them which style they're supposed to be using. And it changes every 12 minutes for a total of 48 minutes. And the person's alternating between motivational interviewing, that is trying to elicit change talk, and doing a functional analysis, which is a well-defined behavioral procedure for looking for the antecedents and consequences of behavior. So here's what we found. In the first session of motivational interviewing, the first 12 minutes, you get a 1.6 ratio between change talk and sustained talk. That's pretty good balance. Then you switch to 12 minutes of functional analysis and it reverses. And now it goes in the other direction. There's more sustained talk than change talk. Then you switch to motivational interviewing. Now you got 2-to-1 ratio. And that's right about the ratio that I find predicts change actually happening. And then you go back to functional analysis and it switches again. And it was all counterbalanced. Sometimes motivational interviewing came first and sometimes functional analysis came first. But obviously the ratio between change talk and sustained talk, which is what predicts change, is very affected by what the counselor is doing. We're just about to release the 4th edition of motivational interviewing in August of this year. There have now been more than 2,000 controlled trials of motivational interviewing worldwide across an amazing variety of helping professions and problem areas. So much so that there are more than 200 meta-analyses and systematic reviews of research of motivational interviewing. So this is a large outcome literature. General conclusions: MI is better than no treatment or a waiting list or just giving people brief advice. So it's more effective than those things. You get a small to medium effect across all kinds of settings and providers and problem areas, change targets. It improves outcome when you add it to another evidence-based treatment. There's high variability in outcome depending on who provides it, on the site and on the study. So about 1/4 of these controlled trials have found no effect of motivational interviewing. About 3/4 do. That difference is partially attributable to the quality of fidelity of MI that's being provided. So I can't tell you the number of trials there are where we trained our residents in motivational interviewing for 6 hours. Then they did it with patients, it didn't work. Well, you can't tell if anybody ever even got motivational interviewing or what the quality of it was. And interestingly, when compared with more longer, extensive or intensive treatments, the results are often similar or the same with motivational interviewing, as you saw with the Project Match trial. All now widely used in healthcare as well. The 2nd edition of the healthcare book is out, being used certainly in primary care, but in diabetes education. I was diagnosed with diabetes 16 years ago and was sent to a 90-minute lecture from a diabetes educator. And I sat there thinking, I may know a better way to do this, and wound up writing a book on diabetes care and motivational interviewing, being used in helping people to adhere with their medication, which is a big issue both in psychiatry and in healthcare in general, chronic disease management. It's an evidence-based treatment in smoking cessation, used a lot in chronic disease management and also in public health interventions, adopting clean water procedures in Africa, for example. And in Project Match, we come up with this combination of motivational interviewing plus always getting feedback based on assessment. That came to be called motivational enhancement therapy. But all that is assessment feedback plus the style of motivational interviewing. It's intended for early engagement of people who might otherwise not show up for care. Meant to have a low threshold. When we've announced this in our community, we've said this is not treatment. This is a healthcare checkup. You'll get information. What you do with it is up to you. We have used measures sensitive to the early effects of alcohol. And we give people feedback in an MI kind of style. And what we found is substantial reductions in drinking, more than 50% in this case, on the yellow line after receiving this single intervention. Then the waiting list group, which is the more red-orange one, then they decline when they get the feedback and motivational interviewing. But again, they kind of splash up back. Why is it that people that are asked to wait for an intervention don't do as well in the long run as those who get it right away? Here's percent days abstinent in the Project Match trial. And the yellow line is motivational enhancement therapy, and it hangs in there with the other two, which were much longer. They were 12 sessions versus 4 for motivational enhancement therapy. With good maintenance over 15 months of follow-up. And there's SBIRT, which Rich was very involved with, screening, brief intervention, referral to treatment. Again, meant to identify people at earlier stages of problematic drinking. So screening for it, doing a brief intervention, and when necessary, referring to treatment. The referring to treatment part is often tricky because people don't get there, but at least it's doing a brief intervention and, when necessary, giving referral to treatment. And you get average reductions and odds ratio of 0.5 through 3 in heavy drinking days, and even in stimulant use, reduction of 0.58 odds ratio with SBIRT. So here's another intervention that can be done in healthcare settings, heavily influenced by motivational interviewing, and quite effective. Now I wrote another book in 2021 with Terry Moyers. And here we were just interested in why is it that therapists get such different outcomes, even if they're doing what's allegedly the same treatment, even if they're using the same manual guided treatment and the same procedures. One of the best predictors of how clients do is who treated them. And that's been known for a very long time in psychotherapy research, that all therapists are not equal. Even if you try to equalize them in a controlled trial, you still get very different outcomes depending on who did the treatment. What we found in going through 70 years of psychotherapy research was 8 characteristics of therapists who get better success rates, whose clients fare better and show more change, receiving the same treatment as their peers were allegedly providing as well. And these 8 characteristics are the ones that emerge from the literature. After we finished that book, I looked at this list and I said, this looks familiar. This sounds an awful lot like motivational interviewing, because accurate empathy has been foundational in motivational interviewing from the beginning. If you don't have that skill, you can't do motivational interviewing. Expressing positive regard, affirming your client's strengths and what they're doing well. Again, from the very first article, 1983, that's been a part of motivational interviewing. Genuineness, not so much. Steve Rolnick and I hadn't talked about it at all, really, not very much in our first 3 editions. And we fixed that now in the 4th edition because of this book, because it's something else that is associated with better outcomes. Acceptance, accepting people as they are, is a key element of the spirit of motivational interviewing. Having a clear focus and goals for treatment and a plan for getting there. More successful psychotherapists do that, and that's been a part of MI from the beginning. Focusing is one of the key processes in MI. Evoking hope, again, from the very beginning, supporting self-efficacy. Evoking from clients what predicts change, and in our case, that's change talk. Doing things to change the balance of change talk and sustained talk in a session, which in fact influences whether people change or not. And then giving information and advice also has a small effect, but nonetheless a positive effect in producing change. So I began to wonder, is that what we've been studying all these years? I mean, is that what motivational interviewing is, really a sort of operationalization of these helping skills that improve efficacy of other kinds of treatment, whatever the treatment is, across schools of psychotherapy, whatever. Another early intervention thing that I got interested in, thanks to Bob Myers, was the community reinforcement and family training approach, which is now disseminating well. Basically, it's empowering family members. Instead of telling them there's nothing you can do, you need to detach, to say there's a lot you can do, and to use positive reinforcement, not punishment, nothing aversive, but positive reinforcement and some extinction to begin to change drinking behavior or drug use behavior. In our first clinical trial of this, we pitted community reinforcement approach, CRAFT, against two other widely practiced approaches for helping family members to get their loved one in treatment and changed. One of them is Al-Anon facilitation. So that was a 12-session treatment designed to help the loved one get engaged in Al-Anon and to follow the steps, done by people whom that's what they do with their lives. I mean, they believe in that approach, they practice it, that they're expert in it. I mean, so every one of these is delivered by true believers. The Johnson Institute intervention, which is kind of the confrontational surprise party of calling people the person comes into the room and there's a whole group of their family and friends who confront them with what they see. And ideally there's a car with the engine running at the curb to take them out to a treatment program. So we randomly assigned families to these three different forms of support. In all three, the family got better, less depressed, less angry, sensed a better cohesion of the family, decrease in conflict in the family, and more happy in their family relationships. So the family always benefited. But the engagement rates were very different. 13% with Al-Anon, 22% with the Johnson Institute, 64% with CRAFT. So when it came to getting the loved one into treatment, an enormous difference. You don't even need statistics to look at that and say that's different. That's now replicated across multiple investigators and nations. And we're running right around 2/3 on average of people getting into treatment using this CRAFT approach. And when it's been compared with other interventions like Al-Anon or Johnson or a wait list, it always looks better. So in sum, it's possible to identify, engage, and treat people who are at risk of developing alcohol use disorders, at risk of medical harm, at risk of family harm, or lots of psychological problems. It's possible to find them earlier and engage them, not through formal treatment programs necessarily, but to do something that really helps them. SBIRT is one of those things. And the drinkers checkup, I like it. We advertised that in the newspaper here, and the phone didn't stop ringing for some time. People called up, wanted to come in and take the checkup and get the information. It was free. And we said, this is not part of a treatment program. So lots of people came who had never been near a treatment program and probably wouldn't go to one. It's possible to interview. Oh, and by the way, one thing we learned is we advertised and said, this is for people who wonder whether drinking might be harming them. And what we learned is if you wonder whether drinking is harming you, it is. Everybody who came in when we did the checkup, where there were reasons for concern there. You can engage them through family members, even when they're unmotivated and refuse to go to treatment and don't seem to have any concern about it. There are various ways to work through concerned family members unilaterally to help the family and to get the person engaged in treatment. CRAFT is a prime example of that. You can also mainstream substance use services in routine healthcare. That's part of what SBIRT was about. Routine healthcare and social services, which is where these people are showing up. I mean, when you say we don't want alcohol and drug users around the hospital, they are already there. They're already there in the mental health clinics. They're already there in the probation offices. They're already there in the employment and welfare offices. They're in all these places, greatly overrepresented. And those are places where you can find them and do something early. And there are things you can do for people early on. what we described in controlling your drinking is essentially behavioral self-control training, which can result either in moderation or in abstinence. As I said, more people who came to learn moderation actually quit than sustained moderation over a long period of time. Some people did sustain moderation over time, and they were people who had less severe problems to begin with. But there's something you can do to help people when they're not motivated for treatment, at least the kind of treatment that we provide. Self-directed change is far better than waiting lists. I think we should simply get rid of waiting lists and see people right away and do at least one session with them that gives them something that's likely to help them. And that's very possible to do. Motivational interviewing and enhancement therapy, those are things that don't take a long period of time. You can intervene at any stage of problem development, and it seems to be helpful. And craft is another example. When only the family members are worried, you can help them and their loved one as well. So that's my talk about going upstream. It was what I wanted to do at the beginning of my career. It's something I've been doing through my whole career. And I think it's a compassionate thing to do, to try to find people at earlier stages of problem development, whatever it is, when it's usually easier to do something. And to do something that maybe doesn't fit into our classic idea of treatment or intervention, but is something effective and compassionate you can do that makes a difference. So with that, I'm happy to take some questions. I think we've got time, and I believe that someone has been tracking those that have come in through the Q&A. And if you want to pose them, you can still do that. And Pete will continue to track them and offer them to me, and I'll do what I can to respond to them.
Great, thank you.
What do you see, Pete?
Thank you so much for those remarks, Dr. Miller. David Koss had the first question submitted this evening, and he asked, since a number of us have ordered the 4th edition due out this August, we're probably going to want to learn some of the key differences between the 3rd and 4th edition. And he was curious how much relearning of the core skills and processes will be, needed as you move from that 3rd to 4th edition.
Okay. First of all, I have a handout that I can send you if you just email me, which describes what's changing in the 4th edition. If you've been teaching motivational interviewing, the changes may not be huge. The processes are still the same. We call them tasks now. Engaging, focusing, evoking, and planning. Change talk is still the same. Change and sustained talk, the same kinds that I just told you. So many of the things that are fundamentals are the same. But we've learned a lot in 10 years. Steve and I once again completely rewrote the book. So we didn't go through and do minor tinkering with what was there before. We started over. And what we had in mind was what's been called the simplicity beyond complexity. We were inspired by a quote from Oliver Wendell Holmes that said, I wouldn't give a fig for simplicity on this side of complexity. Like telling people, just love your clients. It's way oversimplified. But having learned all of this, when you understand something really well after 40 years, sometimes it's easier to explain it in simple terms. And that's what we tried to do. The 4th edition is 30% smaller than the 3rd edition. So it's actually a smaller book. And we really have focused on what's most important, what's fundamental. What have we learned, including in the last 10 years, to help us with this? There are things we know now, just give you an example, that we didn't know at the time of the 3rd edition, which is sometimes sustained talk is a stronger predictor of outcome than change talk is. So it's not only evoking change talk, but doing what you can to soften sustained talk as well. So there are things that keep popping up in the literature that help us do it better and teach it better. But the fundamentals are still there. And it's been the same method from the beginning. We just understand it better. And I think are better able to explain it in simpler terms now.
Thank you. Timothy asked a lengthy question that I'm going to shorten to, as folks think about using motivational interviewing and the OARS model in communication with loved ones, for example, as a part of the Smart Recovery Family and Friends program, do you have advice for those folks who are not trained clinicians or mental health counselors, in using those same tools with their loved ones in a non-professional setting?
Oh, yeah. Well, that's another thing that's changed with the 4th edition, that there are so many helping professions using MI now that it's way beyond counseling and psychotherapy, and even beyond healthcare. So this is being used by educators, being used by attorneys, being used by financial planners, being used by all kinds of people who are not mental health professionals. And so in writing the 4th edition, we had that in our mind, and to not assume people know psychotherapy jargon or are thinking in that way. We kept boxes called for therapists, so we're still speaking to people who do that. But the guts of it, of teaching, for example, the listening skills, are still the same. And so when we included parents and the people we were thinking about in writing this edition, and have some examples of it there. So it's not fundamentally different teaching accurate empathy or empathic listening to people who are not mental health professionals. In fact, sometimes it's easier when you're not working against 20 years of graduate education that pushed in the other direction. So it's not fundamentally different. You're still teaching the same kinds of skills. The ability to learn them is unrelated to years of education. At which point I say even people with doctoral degrees can learn this. But you don't need a certain amount of education to know how to do this as a human being. You maybe adjust your training somewhat, but these empathic skills are just fundamentally something that you can learn how to do. So I think the OARS skills are the same. And it's not like there's a secret version that only the mental health practitioners get. They're pretty much the same, whatever your role or helping profession is.
Great. Thank you.
I did write a book called Listening Well for a general public that specifically focuses on empathic understanding and how to do that, and have a series of learning steps in there. So for people from in a lay audience, that might be a helpful resource.
Great. Thank you. Tom Horvath asked, why are individuals with addictive problems stigmatized? What might we do that is effective to reduce stigma? And I guess I would maybe just add a little bit to the end of Tom's question. I'm curious in particular, as we try to do outreach to primary care physicians, what can we do to reduce stigma in the medical field about those who struggle with alcohol use disorder, substance use disorder, as we try to move that help upstream? Because I think Smart Recovery would be a great option for primary care physicians to mention to clients as something they can do in the immediate term.
Sure. Hey, Tom, by the way, good to at least indirectly hear from you. I think we made a serious mistake in making treatment of substance use disorders a specialty, isolated from the rest of mental health care and healthcare, and getting it mainstreamed. It's co-housed with healthcare. You have a behavioral health specialist right there in your medical practice. And so you can do a warm handoff when a person's trying to change their diet for their diabetes, or change their drinking or stop smoking or whatever. Often the primary medical providers don't have time to do that, but we know how to do it. And we know that if you try to refer people out to an outside resource, they usually don't get there. But if they're just down the hall, it becomes a normal part of healthcare. And we've done that kind of co-location of behavioral health providers in healthcare centers here in Albuquerque. It takes the docs a while to get used to it. And then about 6 months in, they really like it. And we'll even call the behavioral provider into a session with the patient and introduce them and have them talk a little bit about what they can do. So I think the mistake we made was making it isolated and something that is a secret knowledge only those specialists over there know. Nonsense. I mean, the kinds of treatments that work well with other kinds of things that we're treating as well. The problems come intermixed with all kinds of other medical and mental health problems. Treating it in an isolated setting just really never made that much sense. So that's one thing. Changing our language. I mean, we did a diagnostic manual, and for a long time it's been the norm that you don't describe a person, you describe a disorder. So diabetes, not diabetics. Alcohol use disorder, not alcoholics. Depression, not depressives. So it's a habit that you can begin training in medical school and social work and other psychology and other fields. But cleaning up our language is an important piece of it. Education about substance use disorders that is not disease focused, is not you have something wrong with you that has these peculiar signs. This is behavior that gets people in trouble. You drink too much, I don't care what your diagnosis is, you can get into trouble with that, like smoking. And we are now screening for alcohol use, at least supposed to be in primary care. Sometimes it's way too cursory, but doing the expert kind of thing of asking how much you're drinking, how often, and so forth, that begins to normalize this. It's just behavior. That's what we're dealing with, not something weird and strange and special. And so mainstreaming it and co-locating it and addressing it right in primary care. It has been aided by having some medications that the PCP can prescribe, but even better to co-locate services. I think it's in our training that we can make this difference, at least for future professions. Mm-hmm. By the way, I'm willing to stick around past the hour if there's still questions that people would like addressed. So we don't, from my perspective at least, we don't have to stop right on the hour.
Okay, thank you, Dr. Mel. Jeffrey Samet asked, are MI outcomes different when addressing opioids compared to alcohol?
Yeah, boy, are they ever. Yeah. MI is not a freestanding treatment for opioid addiction. It's done in concert with other evidence-based approaches, which is being done in so many medical and behavioral health fields anyhow. But that's one where this is not sufficient unto itself. Espert can make a real difference in drinking. I mean, you may occasionally have an impact with a brief intervention with somebody with opioid disorder, but it's not so likely. So this is not an evidence-based treatment by itself. And I've more and more been thinking of motivational interviewing as a way of doing what else you do, as a way of doing medication management, as a way of doing diabetes education, as a way of coaching sports, as a way of teaching in the classroom. It's the interpersonal helping style that makes helpers more helpful. So it's combined with, but this is not, it's not an evidence-based treatment by itself for opiate use disorders.
Nikki asked if you had any recommendations for books for a newly diagnosed PTSD patient who has a substance use disorder.
Oh boy. Write one. I don't, no. I mean, there are pieces of it. I've done some things for the change companies that are educational, but MI designed manuals you can put in the hands of patients. But the combination of substance use disorders and post-traumatic injury, by the way, there's another one of those changes. General Chanelli suggested that we not use the term post-traumatic stress disorder, but call it post-traumatic stress injury. Now for diagnosis, you may still have to use it, but in talking to patients, injury is something that happened to you. Disorder is something that's wrong with you. And particularly dealing with soldiers, particularly dealing with combat veterans, that's an injury that they sustained and that's very treatable. And just that shift in thinking can be important. So I was trying to say the only thing I've written for the change companies that combines those directly is for soldiers, is for returning veterans, warriors, basically. But it could be put together in a book quite well, and there may be good one out there. It doesn't occur to me right off the top.
Catherine Gill asked, for those of us who are unfamiliar with CRAFT, is it a program available at various treatment centers or a self-directed program for families? In other words, who administers it and where is it available? And I guess I'll just add before you answer that question that, CRAFT is a part of the Smart Family and Friends program. Our program is based on some of the concepts in CRAFT.
Mhm.
So that is one place where one can encounter some of what is in the CRAFT program. But if you could answer, kind of where else can folks kind of find CRAFT?
Sure, but there's one good source that's available in quite a few places, the Smart Recovery program. Often in cities, there's no one who's been trained in this. And although the demand for training is going up and Bob's doing a lot of traveling, it's still, I think, more rare to find somebody who really knows how to do this. But there may be, so there are more and more people being trained. There is a self-help version, a book called Get Your Loved Ones Sober that Bob Myers wrote with Brenda Wolf, I think. And we evaluated it as a controlled condition in a trial. And what we found was it was about half as successful as CRAFT itself, but half as successful as therapist-delivered CRAFT is still better than the alternatives by far. So there is a self-help version that you can put into people's hands in book form that seems to be helpful.
An anonymous attendee asked, how do I get a copy of the drinker's checkup mentioned during the webinar?
It should be available free. The Motivational Enhancement Therapy Manual was published by NIH, the National Institute on Alcohol Abuse and Alcoholism, which is part of National Institutes of Health. And so it's a public domain document. I haven't tried to get a free copy of it recently, but it's not like copyrighted and you can only get it from the people that own the copyright. It's out there. So that's probably the most available form.
Okay, great. There are quite a few other questions, so I'm trying to scroll through to see if I can find some that are kind of representative of one another. So one person did ask a question about the fact that you mentioned the lower education level of clinicians who are working with use disorders, and that, it seemed to imply that maybe more degrees are needed. And this person asked, does it make sense to focus more on peer support or lay people when trying to tackle addiction as a whole? So I guess it sounds like just kind of questioning, is there a role for that peer support, kind of less educated role?
Absolutely. Absolutely. And particularly these skills of motivational interviewing, you don't need advanced degrees. And again, advanced degrees can get in the way of learning it, as a matter of fact. And so that's something that can be taught to people who are peer helpers, and they can become good at it. The years of education required to get certified, stamped, approved to be an addiction treatment professional has been ongoing debate. But specialized treatment is not the long-term answer either. Early intervention, getting this out into the mainstream, I think much more a priority for me than trying to get more specialist treatment programs out there. Specialist treatment touches a pretty small proportion of people with substance use disorders. So I think, yes, so this is certainly accessible to people who are non-degreed, whatever level of education, who are helpers. And by the way, it doesn't seem to matter whether you yourself have a history of addiction. which is another important thing to know. That you can be a helper, maybe not a peer in the same sense, but peer in the sense of just another person in the community, not a licensed certified professional who can help people. And whether you have a degree or a history of addiction yourself doesn't seem to matter. It makes you a little more credible initially if you have a history, but in terms of outcomes, it doesn't seem to matter.
Mhm. Maybe a couple more. Amy Hansen wanted to make sure I thanked you for your comments this evening. And she was asking whether you have any advice regarding the choice that folks make to lie to keep their drinking a secret. She says, any advice for those of us that chose to lie to keep our drinking a secret? And so just, your thoughts on kind of maybe the honesty, kind of piece of, the struggle that folks have, with lying or honesty as a part of their journey to end addiction.
Yeah, most common within families, I suppose. A family member trying to keep secret the amount that they're drinking or even the fact that they're drinking. And it creates an additional problem for the relationship. Because if you're in a relationship with someone you care about and you're lying to them, there's huge dissonance in that, even for the person who's doing the lying, let alone for the person who's being lied to when they discover it. And so it is a problem within relationships anyhow. It may exacerbate the drinking. I don't know. If you're always drinking in a secreted setting, there's less influence on how much you drink, really. Better to be in relationship with people who care about you. And lying about it just creates an additional problem that ultimately will probably come out anyhow.
Hank Robb asked, what are your thoughts on the invitation to change approach?
I guess I don't know enough about it to say something smart. Invitation to change. Yeah.
So I think it's the newest program from the Center for Motivation and Change, and it also, includes components of craft in it. So I'm assuming that's why the question was asked.
I've been retired 16 years now, so I'm not keeping up with the new stuff as well.
Great, thank you. Let me see if there's anything else. I think we've made our way through. One more. I got to make sure I get in the question from my board president.
Oh, it'd be a good idea. Yeah.
So Bill Greer asked, since abstinence isn't a great measure of success, what might you see as more useful as a measure of success?
Well, abstinence is a good measure of success. Percent days abstinent. And that's kind of what's come to be used as an outcome measure in clinical trials now. Not the presence or absence of abstinence, but we are trying to get people to abstain more completely. If that's their choice, that's good. But at least to be drinking on fewer days and drinking less on days when they do drink, that's the kind of direction of a good outcome. And one of the great things about working in the alcohol field is you have a great outcome measure. How much is the person drinking? If you haven't changed that, you probably haven't helped them a whole lot. So percent days abstinent has become normal outcome measure. It's just different from a survival curve. Are you still abstinent? Yes or no?
Right. And
if the answer is no, then you're a failure.
So the problem is really adopting the perfectionist version of abstinence as opposed to measuring the reduction of harm.
Which we don't do with other chronic diseases.
Right.
Yeah.
Okay, great.
We don't shame people who are diabetics who come back with a high blood sugar. You relapsed.
Yep.
That's just silly.
Great. Well, I did see one question asking if we could post the handout showing the differences between the third and fourth version on our website. So that would be something that if you, I'll email with you and get that document that we can post
Sure,
so that our
sure.
community has access to it.
Mhm.
There were, several other people that asked questions that we did not get to, but I think, kind of the gist of them got covered by other questions. Lots of good questions, lots of people saying thank you for your time and your insights this evening. I'll add my thanks as well.
Mhm.
And again, I think we did a nice job remembering Dr. Saitz this evening. I thought you
Indeed.
mentioned him several times, where his work was relevant to what you were sharing with us. And so definitely appreciate that.
Untimely departed.
Well, with that, I will wrap up the webinar this evening. Thank you to all who attended and to you, Dr. Miller, for your remarks tonight.
Thank you for your coming and your interest. Bye.
Have a good evening.